the chat. You can go ahead and answer them.
Okay.
I'm just
So
fixing YouTube for a
that's
second.
optimal. That's optimal electrolyte. Deborah, as you know,
And
Marge is
answer them.
a therapist.
I'm just
So
fixing
that's
YouTube for a
oh,
second.
Carrie is a restorative health practitioner. We have 4 restorative health practitioners in the cohort that just graduated.
Yes. Oh my gosh, that's such a fantastic training. They are so well prepared.
Yeah.
That's yeah,
And
that's
Angela's an RN would really be very powerful.
yeah. Joni's here, and Joni's an orphan who just finished the program. So
Wow, Susan's an MD, pulmonologist, sleep coach. I don't know what CCM is. I'm very close to Cupertino, Sally. I'm in West San Jose, but I could throw a rock over to Cupertino.
who's in anyone in the East Coast here, New Jersey?
Patricia's from Pennsylvania.
My neck
Lisa's
of the
an RN.
woods.
Catherine's a PT from Florida, a
Yay.
dietitian. We've got Canadians here.
Great. Love it. Dr. Millman and I are very prompt, so we'll start pretty close to time, right?
Oh, Ruth grew up in New Jersey. She's in Tucson now.
Oh, wow. I actually grew up in New York, but not very far away.
Thank you.
Oh, another New Jersey. What part? Let me see what I missed that. What part of New Jersey? Let me go look.
Speech language pathologist. Very nice. All right. Cindy's a retired dietitian, nutritionist.
We have retired people who have come back, right?
Absolutely do. They're living their purpose.
I can't let anybody, people have asked, this has happened before, where people ask if they could copy, do things. The problem is, let me go back to the Zoom. The problem is it messes up, it sometimes has messed up the recording. So, but you'll get the recording. We're giving you the recording. So don't worry about taking notes or things. You'll be getting this. But I've noticed that when I've let, because I'm getting some things to somebody's notes wants to take something, but when I've done that before, it's sort of messed up things in the recording. I don't know why, but I don't want to mess up the recording. Okay. I think we'll get started in a minute, right? We'll give it 2 minutes. How's that, right? Right, Dr.
Oh,
Miller?
that's plenty of time for
We have
people.
a lot of information to share. So
Yeah. Julie's a retired RN.
yeah, sometimes you're retired and then something pulls you back in, right? Were you retired, Jonah? You were, right?
She was definitely retired.
Okay.
I'm gonna have to set up my slides for a little.
Yeah, I think we should get started. What do you think? We'll give it 2 more minutes. And then people can jump on as they jump on.
Margie, would you make me co-host, please?
Oh, yes, you and Dr.
And
Bill.
me too. Yeah.
Yes, very important. My goodness. Okay, Paula's co-host. And Paula, everybody are the most amazing. I don't even know if I can call you an assistant. You're like the most important thing, Paula.
She has a
Wait, what's her
title.
title? We gave her a title. What's her
She's program coordinator.
program coordinator? Yes. So she'll be in the chat, helping you. Oh, Kimberly's here. Hello, Kimberly. That's so nice that you came. Yeah, good to see you. Kimberly also is one of our people who finished the practitioner program. Okay. All right. I say we get started. What do you think? So, okay.
Yeah, let's
Okay.
do
So what
it.
I'm going to do, I'm going to hang on 1 second. Oh, let me record. That would be very helpful, wouldn't it? Okay, hang on 1 second. Okay. I'm just going to pin us for the moment and pin you. Okay, welcome everybody on our to our webinar on lab testing. And what's the actual name of it, Dr. Millman? The full name?
It's essential lab testing. Discover the full picture of bone loss.
And we are just, Dr. Millman and I are just so incredibly excited and happy that you've taken the time to be here with us. You know, osteoporosis and low bone mass are incredibly common among postmenopausal women. In fact, believe it or not, they are more prevalent than diabetes, cancer, or coronary artery disease. We are truly facing an epidemic. And yet, despite how common this is, so many people are still being told some version of the same thing. Take calcium, vitamin D, take a medication, and do some weight bearing exercise. If you've heard that, just write in the chat, yes, I've heard that. But as practitioners, we know it is not that simple because osteoporosis is not a one size fits all diagnosis. We need to dig in and discover the root causes. And if we're not identifying those underlying drivers of bone loss, we're missing the opportunity to truly help our patients and clients. And that is exactly why today's conversation matters so much because you, the practitioners, are the people who are going to make things, who are really going to make a difference and who are perfectly positioned to change the trajectory of osteoporosis. That is why it's so important that if you work with these clients, that you have the tools to prevent the debilitating fractures, deaths, and loss of independence that too many suffer. So, for those who don't know me, I'm Margie Bissinger. I'm a physical therapist and integrative health coach, and I've been working with people with osteoporosis and low bone mass for over 30 years. I'm also the co-founder of the Bone Health Academy and co-creator of the Certified Integrated Bone Health Practitioner program, where we train professionals to take a comprehensive root cause approach to bone health. And I'm just so excited to be here with my colleague and co-founder of the Academy and certification, Dr. Kim Millman, who brings an incredible depth of clinical insight to this work. So, Dr. Millman, I'd love for you to introduce yourself.
Well, hello, everybody, and I'm really glad that you took the time out of your busy days to be with us. I am Dr. Kim Millman. I have a thriving medical practice in Silicon Valley here in California, and I've been specializing in osteoporosis and in bone loss for 18 years now. I love it. My mission is to provide real effective science-based protocols and frameworks for my patients to get absolutely incredible results and to train other practitioners to do the same. And we're so excited that you're here with us so that you can see if that might be your mission too.
So how this is going to work is Dr. Millman's going to go through with the webinar, which is next, which is just so informative. But don't worry, there is a tremendous amount of information. As I said earlier, you'll be getting the replay. So don't feel you have to like take it all in and take notes because you will get the replay. So that's the first thing on the agenda. Then after that, what we're going to do, we're going to just introduce you to our program for those people who really want to know what else is possible in terms of working with people with osteoporosis and osteopenia. And then we also have a special treat. We have a few of our practitioners who've just finished our program. So they're just going to share a few insights with you. And then there'll be Q&A. So we have a lot of things in store. And with the Q&A, don't write your questions into chat because it's going to be a live Q&A. So just if you have a question, you can raise your hand. And then when the Q&A starts, Dr. Millman will just go in order of how you raised your hand. So we'll work it that way. And so anything else before I let you take it away, Dr. Millman?
I think that's it.
Okay, so here I'm gonna leave and you can just start. Okay, let me
Okay, so let's dive into our discussion today. We're going to walk through the lab test every practitioner working with bone loss needs to know, including the bone-specific ranges we've developed over decades of clinical work that you're not going to find in any textbook. We want you to understand how to use them, and as you do, it's going to set you apart as a trusted expert. If you want to be the practitioner people trust with bone loss, there are three areas that are absolutely crucial for you to understand. The first is the bone turnover markers, C-telopeptide and propeptide of type 1 collagen. These give you a real-time read on what bone is doing now before you ever see a DEXA scan. The second is hyperparathyroid panel, which consists of all four tests: the parathyroid hormone, calcium, vitamin D, and 24-hour urine calcium. Without all four, you can't tell whether overactive parathyroids are driving bone loss. The third is ruling out a renal leak. The 24-hour urine calcium does double duty here. So bone turnover markers are one of the most important tools in your toolkit. CTX, or C-telopeptide, measures how fast bones are breaking down. P1NP, or propeptide of type 1 collagen, measures how fast bones are building. Both are measured in the blood. What matters is understanding their absolute values and how they compare to one another. And there's so much you can do with these markers. You can get a sense of where someone is in terms of real-time fracture risk. You can determine how urgent the situation, what root causes may be in play, and whether your treatment plan is working, whether that's either following a medication or a natural approach. An experienced practitioner will also know how these markers are expected to change with different therapies, like BHRT. And what I'm finding is that more patients are learning about these markers, and the savvy ones with bone loss are actually going to expect that you know how to use them. So let's dive in. Before you order these, you need to know how to prep your patients. If they're not done right, they're not accurate. They must be done fasting, no food after 8 p.m. the night before, as early in the morning as possible. And when you repeat them, you want to do them at the same time. No collagen, bone broth, or biotin within 48 hours. No strenuous exercise for 24 hours before. And this is one of the reasons that I think that many physicians dismiss these markers. They're not instructing their patients correctly, so the results come back inaccurate, and they conclude the test is unreliable. But the test is not the problem. With the right prep, we can use these markers with finesse. There's also a huge diurnal swing in C-telopeptide. It's highest at 5 o'clock in the morning and lowest at 2 p.m. in the afternoon. And the difference between these 2 points can be as much as 200 points. We check it in the morning because we want to know the patient's highest level. But as you can see, if someone's not getting the right instructions and they take one at 8 in the morning and one at 2 p.m., it looks like the values have changed. Often, this could happen days from each other, and these markers are going to look unreliable. Now let's look at how to interpret them. We'll start with CTX, the bone breakdown marker. The higher the CTX, the more bone is breaking down. We want this on the lower end of the range. The optimal value is 250 to 350 picograms per mil. If you don't learn anything else but this one thing, write it down. CTX is 250 to 350 picograms per mil. So at that level, bones are pretty stable. And then from 350 to 450, there's a little, from 350 to 400, there's a little bit of a gray zone. And over 400, most people are losing bone. And this is where the gap shows up. Conventional reference ranges for postmenopausal women runs from 34 to 37 picograms per mil. So within that range, the lab report comes back normal. In reality, anything over 800 signals an urgent fracture risk. We teach that a CTX this high needs an urgent evaluation of what is driving it and what the possible need is for a short-term medication bridge. Understanding these nuances can be the difference between your patient being safe and suffering a devastating fracture. For P1NP, the optimal range is 30 to 80 nanograms per mil. And then when P1NP is over 80, it signals high bone building. One cause of such a high number could be a compression fracture. And the P1NP this high is exactly the kind of finding that would prompt one of our students to order a spinal x-ray series in order to look for a fracture. So next we're going to look at the ratio between CTX and P1NP. Most often, P1NP will be about 1/10 of the CTX value or higher. So let's say that the CTX is 350. We would want to see P1NP should be 35 or above. And if it is above, then that's great because that means that bone building is at least equal to bone breakdown. If P1NP is much lower than that, then the issue could be on the bone formation side. Root causes that could result in a low P1NP include things like inadequate protein, and you always want to think about this when you have a vegetarian patient, not enough exercise, or low level of bone building hormones, and the bone building hormones are testosterone and progesterone. If the CTX is too high, the issue is on the bone breakdown side. There's too much. And there are many root causes that drive inflammation, that drive CTX to be too high, like inflammation, high cortisol, gut issues, and a lot more. In our practitioner program, we've mapped out the entire framework of which root causes are associated with high CTXs and which ones are associated with low P1NPs. And so the bone turnover markers can guide you to the root causes. Another essential part of the workup is ruling out two things: hyperparathyroidism and a renal leak. Hyperparathyroidism is when the parathyroid glands are too active. And as you know, there are 4 rice-sized parathyroid glands that sit on the butterfly-shaped thyroid gland. To rule it out, we get calcium, parathyroid hormone, 25-hydroxyvitamin D, and a 24-hour urine calcium. A renal leak is when the kidneys don't absorb enough calcium the way they should. They should absorb about 95% of all the calcium that gets filtrated through the blood. And when it's too high, it indicates that the body is losing too much calcium. We rule out a renal leak with a 24-hour urine calcium test. These tests need to be done off of calcium supplements for 3 days. The parathyroid gland is your calcium sensor. It is constantly monitoring the blood calcium and adjusting PTH up or down to keep it in range. Once you understand that, this whole slide makes sense. Let me walk you through the 4 scenarios. Scenario 1 is secondary hyperparathyroidism from low calcium. So if calcium is low normal, and that is 9.2 or below, the parathyroid glands detect that and increase PTH. And I want to note that in conventional medicine, low normal would be 8.8 or below. But at 9.2, parathyroid hormone starts to rise and you start to get a secondary hyperparathyroidism. The cause of the low calcium could be low dietary intake or it could be malabsorption. Either way, PTH brings more calcium into the blood. And in this case, with secondary hyperparathyroidism, hyperparathyroidism from low calcium, vitamin D is normal. So the body's doing exactly what it should be doing, but the root cause is the low calcium, and that's what needs to be addressed. And that is this line right here. Scenario 2 is secondary hyperparathyroidism from low vitamin D. Here, vitamin D is in the 20s or below, and calcium is normal. Vitamin D helps the gut absorb calcium, so when it's low, the parathyroid glands compensate by raising PTH. Low vitamin D needs to be addressed in this particular scenario. Scenario 3 is vitamin D toxicity. When vitamin D is over 100, calcium often goes above 10. The parathyroid glands respond by lowering PTH to bring calcium back down. PTH should be low to low normal, and this is the body protecting itself from too much calcium. And the key here is that vitamin D needs to be addressed, it needs to be increased. Scenario 4, this is absolutely the one that you can't miss. And you really need to know the difference between all four. And I can say that secondary hyperparathyroidism from low calcium happens all the time, and people miss that. So this scenario number 4 is primary hyperparathyroidism. If the calcium is over 10, vitamin D is normal, and the PTH is high or high normal, that is a parathyroidism that is hyperfunctioning, and it could be from a benign tumor. And here's where the gap shows up again. In conventional medicine, hyperparathyroidism is often not flagged unless calcium is over 10.2. But we know that at a calcium of 10, the parathyroid, if it's working correctly, should be suppressed. So the parathyroid hormone should be around 30, 35 because it should not be in the 60s or even worse, abnormally high. And so when you see a parathyroid hormone that is 40 or above, a calcium that is 10 or above, you should be very suspicious of primary hyperparathyroidism. And you know, a lot of physicians miss this because they're looking for a calcium to be over 10.2 and they're looking for a parathyroid hormone to be in the 60s. So both of these things matter a lot, and I hope that you can take this home and use this in your clinics right away if you're seeing patients with bone loss, because this is so incredibly important. And I know that Margie has had so much experience with Diva Boone, one of she's a hyperparathyroid expert, and she had her on the summit. And Margie, do you want to say a few things about what incredible things happened at in your summit?
I couldn't believe what happened in the summit. I've had 4 summits on natural approaches to osteoporosis and bone health. And Diva Boone is a parathyroid surgeon, and she explained this that if you had the patients, had people who were listening, look at your calcium blood work. And each summit, around 20 people found out that they were losing bone because they had hyperparathyroidism. They ended up having surgery. It's a surgery that's very specific, but it's so needed. Otherwise, they're just going to keep losing bone. So it was incredible to me how often this is missed in conventional medicine, and it's something that you must every client, every patient really look at those values because, as Dr. Millman said, the lab values are for all ages. It's a wide amount. And so for someone who's 40 and it's over 10, there's reason that you really need to investigate this. But it just happens so often. I've seen it in my husband's practice. He's picked up numerous people, and you're really going to change their lives. So it's something super important.
And I think the other thing too is that most physicians are looking for a PTH that's abnormally high. And if they don't see it, then, the diagnosis can be missed. But the problem is that if the parathyroids are actually working right and the calcium's over 10, the PTH should be suppressed. It should not be high or high normal. And suppressed means in the 30s. I mean, it's a really big take home point. And I hope that that's something that you can take away with and use right away in your practice.
One more thing I just wanted to say is that a lot of times they're taught in medical school for some reason, just watch it. But if you're watching it, these people are losing bone. So it's not something we want to watch. We want to take action immediately.
Yeah, absolutely. So, in order to evaluate a renal leak, and this is the case where the kidneys are actually wasting calcium, we use the 24-hour urine calcium. And as I mentioned earlier, this should be without calcium supplements for 3 days. And the thresholds we look at is for a woman, anything over 250 milligrams per day would be suspicious. And then for a man, over 300 milligrams per day. And the medical term for this is hypercalciuria. And so a renal leak where it's actually the kidneys that are not absorbing calcium because of kidney disease is actually quite rare. But one of the things that is common is something called metabolic acidosis. And this is where there are things like lactic acids and toxicities that are causing acidities in the body, a diet that is very acidic, not plant rich, and these can cause acidity. And just the metabolic acidosis will start pulling the minerals from the bones, and then you'll lose it in the urine. So, this is actually the most common reason that a 24-hour urine calcium is high. So beyond the big three, bone turnover markers, hyperparathyroid panels, and the renal leak, there are essential bone nutrients we measure as part of the workup. So we're going to get some of the minerals, calcium, magnesium, potassium, of course, 25 hydroxy vitamin D. These are foundational ones. And then we look at some of the B vitamins. MCV helps us to look at B vitamin deficiencies. Homocysteine is a marker of B12, folate, and B2 and TMG deficiencies. And we're going to spend a moment on homocysteine because this is one of the actual root causes that people don't realize. The other piece are the anti-nutrients. So these are the oxalates. And oxalates come from plants and they are like little shards of glass and they embed themselves into tissue. They cause inflammation, they cause pain, they leach nutrients, and they leach the exact same nutrients we are trying to protect in bone. So we're talking about calcium, magnesium, zinc, iron, B vitamins. These are some of the things, and especially B6, these are some of the things that can be leached out from oxalates. So if your patients have symptoms of oxalate toxicity or eats a high oxalate diet, this can be confirmed by a 24-hour urine oxalate or a 24-hour urine citric acid. So homocysteine reflects both B vitamin nutrient status and inflammation status, and it is commonly missed as one of the drivers of bone loss. And in fact, it isn't a marker of density, but it's a marker of quality. And when homocysteine is elevated, it activates osteoclasts, it impairs collagen cross-link formation, and the end result is that bones become stiff and brittle and more prone to fracture. And so homocysteine levels below 8 are optimal for best bone quality, whereas the conventional reference range goes up to 14.5. So once again, we need the bone-specific ranges, not just normal. And homocysteine usually points to B12 or folate deficiency, and this can be affected by genetics. And you can still need B12 and folate in the right active forms, even if vitamin B12 and folate in the blood levels look normal. So to understand gut function, we use the GI map. It's a functional medicine stool test. It does a couple of things for you. It shows you the balance between friendly and unfriendly organisms in the gut, and it has some great intestinal markers, the ability to digest fats and proteins and how much inflammation is present and how much leaky gut there is. So it can be helpful for almost any patient with bone loss, but it becomes a real priority if there are GI complaints or autoimmune disease, because you really start with in the gut with autoimmune disease. And as you know, gut issues don't stay in the gut. They drive systemic symptoms and inflammation, including aches and pains and headaches and brain fog and mood problems and bone disease. And I encourage every one of my patients to do a GI map. This section of the GI map shows the levels of friendly bacteria in the gut. These are your commensal and your keystone bacteria. But here's something interesting. We don't just want the levels to be high enough. We also don't want them to be too high as well. So we want to see that these probiotic bacterial strains are in the green area. This section shows bacterial overgrowth, bacteria that are out of balance in higher concentrations than they should be. And one nice thing about the GI map is it's a real-time quantitative PCR for the DNA of these organisms. So it gives you a reference range, and it always also tells you how high is high. So you have a qualitative. So when I look at something like this, I say that there are 4 overgrown bacteria, and I also say how high is high. Well, this Pseudomonas is 1,000 times too high, because e to the 7 compared to e to the 4 is e to the 3, which is 1,000. And so the GI maps not only do bacteria, but they do H. pylori, they do yeast like Candida, they do protozoa, and they do parasitic worms. So it's a really good way to look at what's going on in your patient's gut. This is one of my favorite parts of the GI map, actually. These intestinal markers tell you so much. The steatocrit tells you whether your patient is malabsorbing fat. And remember that if they're malabsorbing fat, some of the fat soluble vitamins are so important for the bones, like vitamin D and vitamin K. And elastase tells you whether they've got pancreatic insufficiency, whether they need digestive enzymes. Beta glucuronidase has an effect on detoxification, but it also affects their hormones. Secretory IgA is the immune system in their gut and how it's being protected. Calprotectin is inflammation, and some of my Crohn's patients will have calprotectin in the thousands. And zonulin tells you how much of a leaky gut they have, or if they have leaky gut at all. We also look at food sensitivities and intestinal permeability. And in my opinion, every patient with bone loss should get at least wheat and dairy sensitivities. And I love the Vibrant America food zoomers because I feel like they're very specific and they're very sensitive at picking up these reactivities. And as you know, food sensitivities cause leaky gut, and they also cause systemic inflammation, and they can drive digestive issues, autoimmunity, headaches, mood issues, neurological complaints, pain in joints and muscles, and of course, bone loss. This is one of my patient's Zoomer results, and you can see that this is the peptide level sensitivity. These are where the really high technology part of the Zoomers are. And this particular patient had a Zoomer for wheat, dairy, lectin, and grain. And you can see exactly where she is in this little bar graph. So for dairy, she had high reactivities, and for wheat, she did also. So once you have these results, you can eliminate these foods in your patient's diet, drive down the systemic inflammation, help the leaky gut to get better, and then that can help stabilize inflammation all over the body. Blood sugar and insulin resistance increase fracture risk, and even prediabetes can raise the fracture risk by 24%, which is quite incredible because, as you know, that outside of functional medicine, many conventional doctors are just saying, well, we'll do something about your blood sugar when it gets into the diabetic range. So, of course, we're diving deeper. We're looking at A1Cs and fasting insulin. We're looking at the triglyceride to HDL ratio. We're doing the HOMA IRs, and we're getting a better picture of what is happening metabolically with that patient. I love continuous blood glucose monitors because it allows your patient to see a real-time picture of what is happening with each food that they are eating. So really, after someone eats a particular food, the blood glucose shouldn't go up by more than 30 points. If it does, then those glucose spikes are causing ages happening to the protein, the advanced glycation end products. This not only happens to proteins with outside of the bone, but actually also happens to the collagen crosslinks and makes them stiff and brittle. We can test different sugar hacks to see if they're making a difference with CBGMs. So they're really helpful. Inflammation is an obvious root cause of bone loss. So we measure highly sensitive CRP. And if this is high, then there's likely systemic inflammation in the body. But if HSCRP is normal, it doesn't rule out inflammation. As many of you know, it can still be present. And what we teach is a top-down assessment tool to figure out where inflammation is hiding in the body. We also test TSH because if there is hyperthyroidism, then that is a problem. This is going to cause bones to break down very quickly and is absolutely essential to catch. And the other thing that can happen is on a milder sense, somebody could be over medicated. Even slightly, that's a problem for the bones. Hormone deficiencies are a major driver, and when my patients address hormones, it can really be a game changer for them. So it's worth getting baseline values and periodically monitoring. And you especially want to be monitoring hormones if your patients are interested in hormonal therapies. It's not good enough to put someone on hormones and not measure them. And this is especially can be helpful if there are symptoms of low hormones like brain fog, insomnia, hot flashes, and achiness. There are a couple different options for monitoring hormones, and I do both. So, blood testing is the gold standard. It's the least expensive. It's good for following hormones over time. Insurance can cover it. But make sure if you're working with a postmenopausal woman that you get sensitive estradiol and sensitive testosterone. And I also measure DHEA sulfate. You can get dried urine This is the most comprehensive. I use the Dutch test, and you can get a full hormone picture. And if you get the Dutch Plus, you can also get cortisol. And the really important thing that you can get with the Dutch is hormone metabolites. Hormone metabolites are so important because they can tell you, they can give you some risk stratification about whether or not your patient is going down the proliferative pathway or the protective pathway. So this is a dried urine hormone testing panel. You can see that this woman, the purple box is postmenopausal range. The gold star is the beginning of the premenopausal range. And so this patient basically is postmenopausal. She's not on hormones, and she has low estradiol, progesterone, and testosterone, as well as DHEA. Cortisol is the stress hormone, and at high levels, it breaks down the bones, and stress is everywhere. And it's a major contributor, not only to illness but to decreased quality of life. And so this is one piece of the picture we cannot skip. Consider cortisol testing for any patient with bone loss, but especially for your patients who are anxious, for patients who are caretakers. They have so much stress upon them, and sometimes they bear it very well, but their body feels it. And one of the incredible things about doing a dried urine cortisol test is you get something called the cortisol awakening response, or the CAR. And this is a measure for stress resiliency. It serves as a surrogate marker for the HPA, hypothalamic pituitary adrenal axis. This is the communication between the brain and the adrenals. It not only helps you to figure out how stressed your patient's body is, but how their stress response is working. This is the cortisol section from a Dutch Plus, which uses saliva. And you can see that the normal CAR should rise and then should fall. In this patient's, the third value does not fall. So this is a hypersympathetic state, a person who's in fight or flight a predominant amount of time. And this picture is a chronic stress picture, and you can help this patient by knowing this and giving them something like an adrenal adaptogen. This is when stress has been going on for way too long. There is no longer a CAR. There is only a flat cortisol line. So this is when the brain is no longer talking to the adrenals. This CAR is completely flat, and this is a much later picture than the hypersympathetic picture that we saw earlier. This will take more time to resolve, and remember, when there isn't very much cortisol in the body, this is an inflamed person because cortisol is anti-inflammatory. There are many reasons why we want to get heart labs for our bones patients. So cardiovascular health and bone health are deeply connected. Remember the calcium paradox. It's when the bone can be deficient in calcium, but the arteries, the joints, and the kidneys have an excess of calcium. So there are the same processes in the bone are happening in the arterial walls. And so we can be really smart about this and help both situations. When I'm thinking about whether to start a patient on a bone medication, like especially Evenity, or whether I want to recommend hormone therapy to someone, I want to risk stratify their cardiovascular system. So one thing that I do is I look at LP little a. This is the single best genetic determinant of cardiovascular disease. And I also like to get a coronary artery calcium scan. I feel like between the two of these, I have a pretty good sense of what's going on cardiovascularly, their risk, and potentially how much hard plaque that they have. And you can see this arterial wall. These are the Cleveland Heart Labs. When you want to dive deep into the heart labs, F2 isoprostanes are the gold standard for oxidative stress. You can find out not only what is the LDL, but how much of it is oxidized because it must be oxidized to form plaque. ADMA is about nitric oxide. Microalbumin is what does the endothelial wall look like? Is it a leaky blood vessel? HSCRP, of course, is inflammatory, and MPO and LPPLA2. This has to do with how much of inflammation there is in the arterial wall and whether it's actually punctured through. So the advanced Cleveland Heart Labs are very important for people who want to know additional risk, for people who have a family history and for those who have known heart disease. All right, there we go. That is our content section.
Okay, I'm just coming on. Let me change the, why don't you stop sharing? And then I'll come on.
Yeah, people want to put in the chat if that was helpful for them. I'm hoping that you can take one or two things home with you and use it in your practice just as soon as tomorrow.
Yeah, put in the chat your favorite, what is the one, put the one thing that you're gonna put into use right away.
I would love to hear what that is.
Okay,
Thank you, Marta.
okay,
Thank you, Lisa.
okay. I'm just getting I'm coming up. Hang on a second.
Yeah, these are the kinds of tests that you really have to know well, and they're they completely change the game. Really, completely change the game. Um, so Danae, yes, the lipid biomarkers. I have an entire podcast with Margie on the interrelationships between bone health and cardiovascular health. I think it would be great for you to go and listen to it.
Okay, I'm just trying to get my slides up here. I'm going to start again. Let's try here.
Oh, the podcast, all you need to do is just search my name and Margie's name and probably
Paula can put it in the chat.
bone health. Yeah, Paula, can you find that?
Yes, I'll look it up.
Okay. So I have a question. Can you see the slides yet or not yet?
No.
You
No,
cannot
we
see the
can't see
slide.
it.
Okay, let's try again. There's sometimes.
CTX and P1NP have got to be done fasting.
Okay, how about now? Can you see that?
We see them.
Okay, how about, do you see, probably don't, do you see me now? Because I see you. Do you see me in the slides?
We
Yes,
see you.
we see you, yes.
Okay.
I just see slides.
Okay, you don't see me on the side? Or most people see me and the slides?
Maybe Paula, should you pin her?
Yeah, pin me, Paula.
Okay.
Okay, so you see me in the slides now, everybody? Okay.
Yep.
Okay, great. So thank you so much, Dr. Millman. What you just walked through is just one piece, it's an amazing piece, and such an important piece of the framework that we teach inside the Bone Health Academy. But I just want to pause here for a moment because as you were listening, you may have been thinking one of two things. Wow, this is exactly what my patients and clients need, but I'm not fully confident I know how to apply all of this. Or I've just never been trained to look at bone health this way. And that's exactly the gap we created this program to fill. Because it's not enough to just know the labs. This is going to help you, absolutely. But we need to know now the next step, how to interpret them, how to connect the dots, and turn that into a clear plan for your patients or clients that they can actually follow. And just as important, how to do that in a way that fits into your particular practice. So, whether you're already working with this population or you're looking to expand into it, that's what we teach. So, for the next few minutes, I'm just going to show you what we've built and how it can change not only the results you get with your patients or clients, but the role you play as a practitioner. The first thing we teach is the integrative root cause approach. You just saw Dr. Millman demonstrate. Because, as all of you know, bone loss is not just about bone. It's hormonal, inflammatory, digestive, metabolic, and it looks different in every single client or patient. So instead of a one size fits all approach, you're able to look at the person in front of you and ask, what is actually driving your bone loss? And once you can answer that, and this is what I love in doing this for 30 years, over 30, everything changes. That's the beauty of learning this and figuring this out. So this is actually our favorite part that people really like the most that people in the first cohort like the most, because as you know, practitioners are busy, and I'm sure all of you are really busy. And instead of having to create everything from scratch, you get a complete done for you system. So the client program, the practitioner and client guides, the intake forms, templates you can customize, and trackers. It's all there ready to use. That's what we really wanted to do, so that you didn't have to reinvent the wheel. So you can stay focused on what really matters, which is your clinical thinking and helping your patients and clients. Because I remember when I first started, I was building everything myself, writing up handouts, doing this. It took me years, and Dr. Millman took many, many, many years. So our practitioners don't have to do that. They can use these tools right away. And there's a difference between knowing something and being able to put it into practice. And, there's so many courses that will give you the what and the why, but we focus on the how. And that's really how everything comes together. So learning the what, why, and how, integrating lab testing, applying it directly with your patients and clients. And when you combine that with the tools we just talked about, that's when real confidence begins. So the other thing we do know, and this to me is the best part of it, not the best part, but it's just so exciting for us. I mean, there's a tremendous need for this work. There's more than 54 million Americans that have osteoporosis or low bone mass, and there's just not enough practitioners who know how to truly help them. I see this in my own life. My husband's a gynecologist, and while he absolutely supports his patients, there are many who need more time, deeper guidance. So he's been so excited now because we just had our first people who graduated, that now he has practitioners from our first cohort that he can refer to. But he's not the only person. People just, really are looking for people who can help their patients. So when you have this level of training, you really do begin to stand out, because people are looking for answers. Practitioners are looking for someone they can refer to. And this is an area of healthcare that's in both high demand and deeply underserved. That's what's just, people are just, there really aren't many people, seriously, in this niche. So the favorite part of the program that everyone tells us is the live mentorship lab. So every 2 weeks you'll meet with, for people who are interested in the program, you meet with Dr. Millman and me and bring your real cases. You ask questions. We walk you through what's exactly happening with the patient or client in front of you. And that's where the confidence is built. It's not from the reading, but thinking through real cases with guidance and support. And what the practitioners from the first cohort tell us is that this is the part that changes everything. But even if you can't attend live, you can still submit your questions, and we go through, we'll answer, and we answer them. And then just one piece that we also haven't touched on, but it's how do you communicate this work? Because knowing what to do is one thing, but being able to clearly explain your value so patients and clients can seek you out is just as important. So we cover that in the program so that you feel confident not only in doing the work, but also being able to talk about it in a way that connects. And I just want you to take a minute for a minute and just think, imagine that you're practicing in your community and other clinicians are referring their clients to you when a bone health case comes up, and that people are seeking out your expertise because that's what happens. Imagine your days filled with the most grateful clients. I'm telling you, you can ask Dr. Millman and I, the people that we work with are just amazing. They're so appreciative because someone finally understands them. And then look back years from now and know that you've prevented that. This is the second best part of it. Not the second, but probably the best part. You've prevented needless fractures. You've given women, even men, a real plan where no one else can. And that's just what's on the other side of this training and helping people in this area. And so just to bring it all together, that because I really wanted to share this with you for those people who this is that you're interested in. So what you're doing, you're getting the clinical training, the tools to use in practice, the ongoing membership, support so you feel confident every step of the way. And if this resonates with you and you're thinking, yes, this is the direction I want to go, I invite you to learn more and explore. So just go to the Bone Health Academy and .com. And the link is also on the slide. But if it's easier, just take your phone and you can use the QR code and that will take you right to the page. I'll just let those who want to do that for a minute. And it goes into much more detail about the program. So if you're sitting there thinking this is exactly what I've been looking for, here's what you do. Enrollment's now open for the second cohort. Here's the other thing though. There's only 30 spots because we intentionally cap it there because we want every practitioner who's in the program to have real access to Dr. Millman and me during the mentorship labs. And these spots fill up, they do fill. So again, if this program's for qualified practitioners and you can see the backgrounds because you do need to have a background to understand all this. And then in this cohort, the price is $5,000. We've kept it the same as the first cohort. And if you're interested, the next step is go to the link, learn more. You have to submit an application. And if it feels like a good fit, we would absolutely love you to join us. And if you have any questions, you can call the Millman Clinic and speak to Lauren, and that information's on the slide. And, actually, let's put that also in the chat, Paula. And there's also an email too that you can do. So before we get to the Q&A, I'm just going to stop sharing. And before we get, did I take that down too quick or we're good? Okay. Paula, you can put that in the chat. Before we get to the Q&A, we're just going to take a few minutes because I just sometimes, it's nice for Dr. Millman and I for me to talk about this, but we have a couple practitioners here that we're just going to share what their experience. So let's see who's here. Is Anne here? See, I know who's coming. Anne, are you here yet?
I'm here. I can't get to
You're here. You're perfect.
I'm here. I can't see me, but I know I'm here.
You're here and we see you.
Okay.
So why don't you just share with everybody a little bit about tell them what kind of practitioner you are and a little bit about your experience.
Sure. So, like Margie, I am a PT. That is my background. And I'm also trained in functional nutrition and I'm a lifestyle practitioner. And I'm also certified in Buff Bones. This is a Pilates-based program for osteoporosis. I'm certified in that and trained in Bone Fit. So I've already been seeing women with low bone density and osteoporosis. So I didn't come into this course as a beginner, but what I wanted to do was really to refine and elevate my expertise in this area of bone health and osteoporosis. But I also knew that I had some gaps in my knowledge base, and that's what I was really looking for. I'll tell you a few of the areas that were really, really helpful is that Dr. Millman does a phenomenal job on talking about the medications. And this is important, even though I'm not a provider, I can't prescribe, but you are going to have patients coming to you. They will be asking you about medications. So you have to understand them. You want to understand how they work, who they're appropriate for, so that you can better advise your patients or clients if you see clients. It came in really, really handy. I was doing a lecture on osteoporosis. It had nothing to do with medication, and every single question was about medication. So thank goodness I had that background, because I felt really confident in answering those questions in a general way, but it gave them the information that they needed. So really filling gaps in some of these areas. The other one was the menopausal hormone therapy. I needed more background and education on the target serum levels. So this was hugely helpful for me, because again, there's so many women that are on hormone replacement therapy, but they don't understand where they should be in terms of their target levels to actually make a difference in bone, and then understanding the safety behind that. And it's really, really, it was very important to me that I was in a program that was research-based. And boy, is it research-based. Both Dr. Kim and Margie, everything that you learn is so evidence-backed. And I loved this about the program. So you're really going to feel solid when you're speaking to your patients or clients, because you know you have this research behind it, plus all the years of experience they both have working with patients with osteoporosis and low bone density. The other area was the cardiovascular piece. And I just came in at the end of the talk here, but it sounds like you were talking a lot about the cardiovascular connection to bone health, which is so important. And so I learned a lot more about that as well. The other thing that you mentioned, Margie, at the end here that I was really looking for was mentorship, and having someone be able to look at your cases. I out the gate, I think I presented cases the day one, and probably for most of the Q&As, I had case studies. This is huge, you guys, to be able to have someone with the expertise and the clinical experience to look at your cases and give, a deeper or another lens of looking at that case and giving you recommendations. This was huge for me. Totally love that piece. And then, excuse me, the other thing that was really important too is to be able to elevate my practice a little bit more with the turnkey program. This is like nothing you've ever seen. There are so many handouts. Besides that, you can brand it with your branding materials. It's so professional. You will feel like you have the whole kit, the whole package together, just by being able to use all of these turnkey materials. These have been so helpful. I started using them day one with my clients. And it really elevates your practice when you can have something that's so professional looking and so complete. And then I can't say enough about Dr. Kim and Margie. I mean, they're like the best team going, because they're so knowledgeable. Dr. Millman, with all her clinical expertise, will blow you out of the water. And Margie as well. Margie, not only from a PT perspective, but also from a coach, because you've coached. So you have both of those seats, which I think is really important experience, and how we can learn even more. So I can only highly, highly, highly recommend this program, whether you're just starting out and you are not really seeing patients yet, or you're in clinical practice, but you want to elevate it and you want it to be more professional. You want to feel really confident about bringing your patients or clients through their osteoporosis journey. That's what you're going to get here. And everything that they do, it's from the heart. It's just, they're so genuine and so giving. And just willing to go above and beyond for us, so patient, have stayed extra. Probably don't want to say that, but stayed extra just to make sure we understood and that we had the information that we needed. So I don't want to hog all the time here, but I hope that was helpful in just talking a little bit about where I was coming from and what that did for me. So I think on any level, you're just going to get so much out of it. So I thank you, Marchie and Dr. Kim, for this program.
Oh, well, thank you so much, Anne. It's been what's happened with Dr. Millman and I is we love everyone. We've gotten so attached. We already are missing.
We're
So
missing not seeing you guys. I can tell you that.
we miss you. Thank you so much, Anne.
Sure.
So we have two more people who are just going to come up before we get started. Then we are staying. Don't worry about the Q&A. We promise we will get to the Q&A. But I think if anybody's interested, it's so helpful to hear from other people. So let's bring Joni on. Joni Cohn, are you there?
Yep, I'm here.
Okay, Joni. So why don't
Hi,
you
Anne
share a little
and
bit
Kimberly.
about your experience?
And you're right. We miss each other. We miss you. And I think I'll start with that point because you've seen, Dr. Millman's expertise. You have a taste of Margie's, but believe me, there's a whole ball of expertise, especially in terms of dealing with stress and ways to reframe things and one of the things that I think is so impressive with the two of them is how and Anne touched upon it, how they relate to one another, to each person. And because and I know in my own process, when I started on this, it was because of my own diagnosis of osteoporosis. And the first thing I felt was abandoned by the, the health people. It's kind of like, well, you better do something. It's like, that's not very helpful. And to have role models who help you from the very beginning, first by how they relate to each of us, as learning, to take one's own power and to feel this hopefulness. And it's like, I can do this. There's a sense, it's like, step by step by step. I always like to use the analogy of the yellow brick road. But the other thing I want to touch on, and then Kimberly, I'll give you a chance, I promise, is you learn a lot also from your other classmates. And you're getting a taste of it here because people come in with different levels of expertise. For me, my background's in nursing, psych mental health nursing. I've done a lot with mindfulness and different kinds of teaching and, working with people. And so I started off with not a lot of information in depth, which I have gained through this program. And I'm glad, Margie, you showed these different parts that as students you have access to. It's like, it's there. The modules are there. There's even transcripts. I mean, everything is done to help you become successful practitioners. But just know that you're never alone. You never feel alone. That there's support throughout the program. And like Anne was saying, it's like, yeah, these poor people, they stay late for us. We send them questions, sometimes really long questions. And you never feel like, oh, that's too much, or you never feel like you asked a stupid question. There's clearly nothing related to that. Everything is a learning experience, is an empowering experience. And I'm going to be quiet so Kimberly can share too. But it's great. I came to it not expecting to, and I feel like I have been guided, that it is part of my purpose. And I'm just kind of developing exactly who my particular clientele might be.
Oh, well, thank you so much, Joni. And it's always, as we said, Dr. Millman and I are so attached to everybody. So thank you for joining us. We really appreciate it. Okay, Kimberly Lemon, why don't you
Can
come
you,
up now?
can you hear me?
Oh, yes, I
You're-
can hear and see you. Hi, Kimberly.
Hi. Yeah, I know. I miss everybody. So everything Annie and Joni said, and uh, yeah, I'm a pharmacist and I have osteoporosis. I feel like I'm at an AA meeting. And so I started on this quest a couple of years ago because, of course, the doctor, right, wants to put you on a medication. And as a pharmacist, I'm used to that. So, and I used to believe that years ago, there was a pill for everything. And then I started learning more about functional medicine and root cause. And I knew that there was more to it. And so I got on this quest, and then it was amazing that I got an email from them saying they were going to offer this program. And I'm like, oh my gosh, it's like perfect. Something that I was looking for because I want to share, I want to make it easy for someone else because it has been a journey for me to learn all this on my own. And this made it, I don't want to say easier, but it was simplified and it was packaged with all the different root causes. And where I was going over here and over here. And so it just brought it together. And it was just really nice. And I love it. And I really hope and plan to share with people that are open. And I think there's a lot of people that are either scared to take medication when they maybe really need to do a short bridge. But to guide them through that and to be there because I don't see providers being there for them and explaining like how we learn in the program to explain and to go deeper. Anyway,
Oh,
thanks.
thank you so much, Kimberly. And I know great things lie ahead. So thank you so much. Okay, really appreciate it. Well, these are just such amazing practitioners. And now Dr. Millman is all set to answer your questions.
Yeah, I'm just wanting to tag on to what Kimberly said. I've actually had patients come into the office and um, so their doctor presents 4 or 5 medications and they say, so which one do you want to take? And it's like they kind of like are thinking, I you're the doctor. Why should I be choosing, right? And like they don't know. They don't know, and they don't know why, they have no idea whether, we teach in the program that there are red flags. And when these red flags happen, then fractures are potentially pretty imminent. And maybe that person needs a short medication bridge. But then there are people who are offered medication. I had somebody who was offered Fosamax the other day, and she had osteopenia. That was it. And so, something's got, you gotta have some sort of a reasonable framework to work through. It's like if somebody can just work on their root causes with osteopenia and just make sure that things don't get worse, then that's the right approach for some people. And I have to say that I think that most people don't need medications, right? Most people don't, but when they do, it's important that they have an understanding of what their options are. And I just don't think that people are getting that from their doctors, unfortunately. All right, so um, okay, so let's go ahead and start with Susan. If anybody in the chat has a question, then let's go ahead and raise your hand, and let's start with Susan G.
Hello, thank you. I am a patient, not a practitioner, and I'm trying to educate myself. And my
Okay.
question is, years ago, I had a neck injury and my circadian rhythm has been off ever since. So it's like 2 or 3 hours skewed to the night. And I'm wondering if CPX, that thing you said is at 5 a.m. that it's the highest. Would it still be at the highest or would it be at a later hour?
Yeah, I actually have this issue with people, so um, I think it does depend on your circadian rhythm, and but I think it also that can also be influenced by you getting the sunlight in your eyes as early as possible.
I've tried all of that. Yeah, because
I'm
I
not,
have practiced.
I guess I'm not necessarily saying how you could improve your sleep because I think your question is around will the
That
CTX be accurate, right? Because
right, right.
there's so
Yes.
much insomnia. So in one of my patients, I just said, just go ahead and rest, keep everything really dark. Um,
Uh,
make an appointment for 8 o'clock in the morning, and then 7 o'clock, wake up and get light in your eyes. Maybe just try to do that for a couple of days, and whether you're the light. I think that the sunlight will help your body not to not it would just I think it's going to help the CTX, and we got some decent CTXs. We did an experiment. We did 3 days in a row, and they were pretty close to one another. So
oh, okay. Thank you. And I will put my name on for your practitioner directory. So
okay,
that will be helpful.
yeah,
Thank you for having
yeah,
that too.
we would love to support you.
Thanks very much.
One,
Uh-huh.
one more thing, when you say your question, tell us what kind of practitioner you are also, because that will help how we answer it.
Yeah, Jenny.
We don't hear you.
We can come back around, Jenny. So Kathleen.
Okay, so I am a retired cardiac nurse, and I just had the GI map done, and it did show that my zonulin levels were high, and that I had some dysbiosis, probably leaky gut. So the practitioner I'm going to wants to do a Zoomer test for wheat and dairy. So I have two questions regarding that. Is that test only for dairy for cows? Or is it also for goats and and all that type of stuff? Because I get a lot of my calcium from cheese. And I find it I find
Yeah,
it difficult
so
enough to get that.
it's cow.
It's
Yeah,
cows.
it's cow. Yeah. They used to have a goat and sheep uh food in the food sensitivity panel, but I think they got rid of that. But they're not, they're pretty closely related species. So if my patient's reactivity is extremely high, I'm going to tell them no dairy whatsoever, including sheep and goat, and then maybe in 9 months bring in some sheep and goat, and then when you bring back the food is a very individual thing. It depends on a lot of different factors. So but usually the sheep and the goat I bring back faster.
Okay. And then the other question is, so when I go to get the Zoomer test, she's especially concerned about wheat and dairy. Should I be eating? So say I'm going to is there a certain time of the day I should do it? And if not, and also should I do it like, right, an hour after I have a dish of pasta, or should I do it? Is it timed with your eating it all with the dairy and
No,
that?
no, there's no fasting constraints. I mean, these are based on antibody levels that have been, well, the IgGs at least. IgGs are memory cells, and those memory cells have been accumulating in your system for usually something like 4 to 8 weeks after eating the food. So it has really nothing to do with fasting states.
Okay, so what I'm saying is, would it be helpful for me to have some wheat or dairy before I do the testing? Or does that not
I
matter?
don't ever recommend somebody, if somebody knows that they're sensitive to something, I don't ever recommend that they go back to that thing just because I don't think it's good for the body. But
We're trying to determine that right now
if a person is
before the
already,
test.
if a person is already eating it, then sure, I mean, eating it, every day for 3 or 4 days beforehand. Some practitioners tell their patients to do that.
Okay. Because if I didn't have it for 2 weeks or something, it might not show up.
It needs to be something like 4 to 8 weeks for the antibodies to go away.
Oh, okay. All right.
And
And
pretty,
my
and
IG,
pretty,
yeah, my IgA was off. It was high.
mm, that's an indication that there's probably something there.
Yeah. Okay. All right. Thank you very much. I just wanted to make sure I did the test correctly.
You're welcome. Melody?
Hi, hi. Thank you for answering questions. I'm a retired hospice RN and I do have osteoporosis. And I was wondering if the 24-hour urine calcium is very high, does that also affect the P1NP and the CTX? And then I was wondering, how do you determine the reason for the renal leak and what treatments there are for it?
Yeah, so usually if there is a very high CTX and there is a very high 24-hour urine calcium, but the 24-hour urine calcium is because of a lot of bone breakdown and turnover, if that makes sense.
Yeah,
So they can kind of confirm each other. And when that happens, and let's say the CTX is really high, the P1NP is high, I'm looking for compression fractures. And if the CTX is kind of normalish, maybe even 600, something like that, but it's not 800, 900. Then, and I've already ruled out I've already ruled out hyperparathyroidism. The most likely thing is metabolic acidosis, and then I do first urine pH strips. And if it's acidic, then the first thing that I do is electrolytes. So pretty moderate to high dose potassium, and then looking also at serum potassium to make sure that that doesn't go up. But that's the most likely thing is a metabolic acidosis if it's not from CTX and PTH.
yeah, the morning urine's probably around 5.5. So,
Yeah, it's really acidic.
yeah, yeah. So that's probably most likely what it is. So
That's most
electrolytes,
likely what
potassium.
it is. And I use the Seeking Health Optimal Electrolytes, a scoop of it. It's got 500 milligrams of, I don't remember if it's potassium citrate or potassium bicarb, but it's really potassium and magnesium that can change that. And then within a couple of weeks, I'm having my patients redo the 24-hour urine or 24-hour. Oh, sorry. I'm having them redo the urine pHs and
Okay,
seeing if that's shifting. If that's shifting, then in a couple months redo the 24-hour urine calcium.
okay.
And sometimes it just really is the kidney. And sometimes, I'm going to send the patient over to renal, right? And have kidney doctor really look at it. Or I might try just like a touch of hydrochlorothiazide. That's the medical fix for it. But a lot of patients with bone loss are thin and they can't tolerate blood pressure medications because they already have low blood pressures.
Yeah, yeah. Mine is already kind of low. Yeah. Okay. Thank you. I appreciate your answering everybody's questions.
You're welcome. We can go back to Ginny if Ginny is,
Hello, can you hear me now?
yeah,
Oh, great. Thank you. I had a question. You had discussed in a previous Q&A genistein,
yeah.
um, and I wondered two things about that. I looked into it a little bit myself, and it's from soy apparently, or it's found in soy. Um, And I wondered if there would be any kind of contraindication to taking that if for a person, say, with Hashimoto's, because I've heard over the years to stay away from soy with the thyroid disorder.
You know, so for Hashimoto's, people should be worried about goitrogens. So things like cruciferous vegetables that are raw. I'm not sure about soy. I mean, I've kind of heard that from people. And the one from Designs for Health is not based on soy. So the
Oh,
Osteoben and the um which one? I always forget this, Paula. It's FemGuard HF? FemGuard
Ye-
HF. Yeah,
Yes.
that's right. So both of those from Designs for Health have 54 milligrams of genistein aglycone in them, and they are from, I think, Japonica saponis kind of flour, something like that, and it's not soy based.
okay. And my other question related to the same thing. You said it.
You know what, Jenny,
Yeah,
just in the interest of allowing people
that's
to
okay. Got it. Yeah.
you can ask if we have more time, we'll be glad to answer another
Okay,
question.
great. Thank you.
And I know that who was it? How come she's gone off of the? She was waiting a long time. I thought her name was Dina. I don't know. Maybe she. I don't. Okay. Kathleen. Oh, Lisa. Lisa D. Lisa. Somehow you came off of the.
I know I've been doing that myself because I wanted to wait and hear all the other questions.
Oh,
You
you
can come
did.
back. You can come
Okay.
back. Yeah,
Oh,
that's fine.
okay. Um, who is the other person? I don't know. Well, and my string of names melody is up next.
Oh, sorry. I forgot to lower my hand. You already answered my question.
Okay. All right.
Call on Paula because she's going to read somebody else's
All
question.
right, Paula.
This question is for Kathy. She had it in the chat. I have what I'm told that I have been told I have severe osteoporosis, especially in my L2. I also have MTHFR and know that it causes issues processing vitamin B, and I also believe vitamin D. What are your thoughts?
Okay, so severe osteoporosis in L2, did you say?
Yes.
And then MTHFR.
Yes.
Well, so anytime somebody has MTHFR, they need to really be looking at homocysteine. Any homocysteine over a level of 15, it carries with it a something like a 2 times risk of fracture when homocysteine is so high. And of course, somebody is going to need something like a methylfolate, an 5-MTHF type of a supplement if they have MTHFR. And so, absolutely, they're not processing folate correctly. I'm not sure that it has anything to do with vitamin D, but severe osteoporosis in one vertebra, can we completely blame MTHFR for that? I think there's probably other things going on besides it, but that's definitely something that can be one of the causes. Okay. All right, Carol.
Yes, hi.
Hi.
First of all, how do I go about finding a well-trained practitioner in this area? Because I am so upset with things people have told me.
Yeah. Yeah, so I mean that's why Margie and I are on the mission that we're on is to not only educate the the people who are dealing with these problems, but also to educate practitioners. And we were this webinar today was actually a practitioner webinar so that we could explain our certification program. Paula has been dropping in the chat a Paula, what are you doing for people? Because we have a wait list of
Yes.
people who are looking for practitioners. We have a couple of new graduates. We have a practitioner directory that we're working on, and it's almost ready to be published. And so we, Paula, what are you doing for people who, Paula, why don't you come on and say what you would like for people to do who want to find a well-trained practitioner from our first cohort?
Hi, everybody. If you are interested in being added to our wait list for the practitioner directory so that you'll be one of the first people to know that it's live, please email us at support@thebonehealthacademy.com and you can just put in the subject line interested practitioner directory and I will add you to the wait list.
Great, thank you.
Yeah.
I also, one thing you mentioned, all other kinds of connections with osteoporosis, but have you had any research with the relationship of calcium deposits in the eyes?
Oh, no, I'm not really looking into that. But it still fits the calcium paradox, which is that the bones can be deficient in calcium and the eyes can have too much calcium. And so really the thing to think about is vitamin K.
Vitamin K. Because my eye practitioner said, oh, you've got to stop all calcium in your diet. And then I don't know if that caused me to get osteoporosis, but now I have severe osteoporosis. But without knowing the root cause of the calcium deposits in my eyes, it goes nowhere. It's like a vicious circle, and I don't know where to go now.
Well, I don't have a lot of specialization in like eye diseases, but what I would say would be that anyone who tells anyone to stop all the calcium in their diet and supplements, they're going to cause a secondary hyperparathyroidism. I mean, it's going to happen.
I know,
So
and right away I said, "What am I going to do? It's going to affect my bones." And he said, "You have to choose your eyes or your bones." So, so
Mm,
I said, I said I'll choose my eyes, but I didn't think it was going to have such a dramatic effect on my bones.
wow.
And doesn't seem to be any specialist because it's a very rare condition. So
Hmm. I'm sorry, I don't have any ideas about how to get the calcium out of your eyes.
oh, there is, they put acid in and they scrape it off, but then if you don't know the root cause, it comes back again.
Well, I would say that the two nutrients that keep calcium out of the soft tissues are vitamin K and magnesium.
Okay. Okay. Thank you.
You're welcome. Barbara, did we see you last Monday?
Yes, I thought I'd come back because it was so interesting.
Oh, good.
I have a couple of questions to follow up on the genistein.
Yeah.
If you're already on HRT, is it okay to take the genistein, or is that too much estrogen?
So, so I'm going to say that I'm going to guess that the estrogen that a lot. So in BHRT, people can be on estradiol and estriol. Estradiol is the strong estrogen, estriol is the weak estrogen. Genistein is a phytoestrogen, and it's an estrogen that comes from plants, and it's weak. A estradiol tends to attach itself to the alpha receptor, which is proliferative, and the estriol and genistein tend to attach to the beta receptor, which is like build bones, cognitive function, kind of all the good stuff is the beta receptor, and the bad stuff is the alpha receptor. Okay, so estradiol strong. It binds to the receptors tightly. It doesn't let go. Estriol and genistein bind weakly. So only if there are estradiol receptors that are available and open will a phytoestrogen or estriol bind.
Okay. Also,
Does that make sense?
yes,
Only
absolutely.
if they're open, right?
Yes,
Otherwise, estradiol will take its place, and
it's a
neither one of
dominant.
those estrogens will knock estradiol off the receptor.
Okay.
So, from my point of view, if a person is on a fair amount of estradiol and they have a good target bone specific range, then probably don't need genistein.
Okay. Also, if someone's on Timlos and what is the best anti-reabsorptive medication to take after you're done the 2 years, and how do you make the decision on which one to take? And
Yeah.
also,
So,
okay,
so I did ask to just do one
okay,
question.
sorry,
So I think it's a good idea for us to just see if we can't get
got
through
it.
everybody, and then if so lower your hand, let everybody do a question, and then you can raise your hand again. We're
Okay,
gonna stop at 4 o'clock. Okay, Lisa D.
Thank you. Thank you to
Yeah.
Margie. Kim, this has been amazing. And I'll try to be brief. I'm a holistic health practitioner. I can barely add 2+2, and I'm really bad at science, so I don't think I qualify for your program. But I have 23 years experience as a colon hydrotherapist, so the gut-brain connection, the gut bones, all that. My current iteration of practice is about to be helping people to heal from trauma. I am a lifelong arthritic person from childhood, and now I'm legitimately aging. I'm 63 and I have osteoporosis. I broke an ankle 4 years ago without even knowing that I was walking on a broken ankle for 5 days.
Oh
Yeah,
no.
nice. Yeah, so I can relate to all these concepts. I can put it all together, but I don't have the science background. So my question is, I learned in my late 40s when I was in practice that unresolved childhood trauma will rear its ugly head in menopause. And by the way, I'm really curious about how this all affects men if they have osteoporosis the way we probably not at the great level that we do. But my point
No,
is that
it's not as common at all. But there,
yeah,
but I've had multiple people in my R&R class too, and that's another any of you guys who are not practitioners, I have a directed to a consumer class called Restore and Rebuild 100 Days to Healthier Bones, and it is very good in the science and helping people through lots of Q&As and that kind of thing. It's in the middle and probably will be offered again in August. If you're interested in Restore and Rebuild, you could drop your emails and say, your email and then R&R next to it, and then Paula can put you on a wait list. But
That was an
um,
aside. The real question is, do you
yeah,
observe,
yeah.
so are comments on this whole thing about unresolved trauma coming up to the forefront during and after menopause? I learned about it when I was in my late 40s. I saw it in my clients, and then I hit the wall myself right after 52. That if that constant unresolved stress from the past is always running in the background, it's affecting us today on top of current day stress and how that would affect the bones. Are you observing that in your practice at all?
That's not something like I dive into. Uh, I really don't. It's not at all in my wheelhouse. Not that I don't appreciate it, but
Yeah.
I would know what to do except for to refer people to the Biology of Trauma's website. That's all I would know how to do, what to do.
Cool.
I can say something. So I think it's really, really important. And I've seen numerous people that really had to work with a therapist and how to do and received so much benefit from doing somatic work. Because as Dr. Mullen showed earlier, the cortisol really breaks down your bone and people don't appreciate this. And so that's something that I teach in their stress, not exactly somatic, but stress and happiness and resilience, and what you can teach your patients. Oh, also, I didn't mention that, everybody. I teach a happiness program and I give that to you. That's that's just like a bonus that you'll get to attend get all the recordings of the happiness program. So it's something that can really help. But I think it's very important. And if I see that in anybody, I do the same thing. Dr. Amy Pigeon has a really wonderful program and practitioners. And I've had so many people, including family members, who have worked with the somatic therapists. And it's just been incredible when other things didn't work. So
I studied with her. I'm glad you guys know about her. Thank you so much. I really appreciate both of you.
Yeah, thank you. Ruth?
Hi, thank you, gals, for this. For everyone, I took Dr. Millman's Restore and Rebuild class before she offered this other one. I'm a certified practitioner, and it's fantastic.
Thank you.
If you're not going to go for the full everything, if you're not certified, I would so recommend it. And I also am part of Margie's group, and that's fantastic. I'm a learning geek. So I just had a quick question about the Scene calcium chews, if you're familiar
Oh,
with them and if you recommend them. I don't do dairy, but I think I could handle those with
yeah,
a
that's the only thing that I'm a little bit concerned about is that they do have dairy in them, and um, that's all I'm concerned about.
I would take I would take a dairy digestive enzyme when I take it, but
Anne, who's one of our practitioners, knows a lot about them. Are you still here, Anne? I don't know if she's still here.
Yeah, I'm still here. Yeah, so there's 1 milligram of the casein in it. So it's definitely not dairy free, but because of the other ingredients, there's mushrooms,
da-
there's dates, there's almonds. They all work very synergistically together to help be better absorbed. So it's a really good product. And for those that are, don't want to be supplement heavy, if they don't have issues with the dairy to that level, then it's a great option.
I mean, what are because I have a lot of women are asking me that don't do dairy. Well, what do I do for calcium? And I don't know, do I recommend calcium citrate or it's tough, you have to be careful. You don't want to do too much calcium or it goes to the wrong places. And
Well,
so I,
you learn all of that in Dr. Kim's course. She goes through all the types of calcium, how much you should be taking, what you should be taking it with. So you get all that information.
But
well,
Ruth's already taken R&R, so she's had quite a bit of it.
yeah, it's just a tricky one. So, okay, just wanted to see what you thought of that particular one. I'm going to give it a try.
All right. Thanks,
Yeah.
Ruth. Cindy?
Oh, can you hear me?
Mhm.
Oh, okay. So I've been diagnosed with osteoporosis for like the last 10, 15 years. And I went on Timlos 2 years ago. And after the first year, it showed a 5% increase in bone mass. After the second year, it showed a decrease,
Hmm.
which
Hmm.
is a little bit worrisome.
Hmm.
I'm seeing the endo tomorrow, but I'm quite concerned. And I'm just wondering, because she wants me to put me on Prolia, which I do not want to do.
On
Uh,
what?
Prolia, she wants me to go on
Oh,
Prolia.
yeah. Okay.
Yeah, so, but I understand from listening to you that the rebound is much less on Timlos than it is with Prolia. And I've heard a few horror stories of women who did do Prolia. And so I'm just wondering
Except if
about.
you know what you're doing with Prolia, it can be okay. And Prolia is especially good at the hip.
Oh, my problem is the spine. The hip is -3, but the spine is -3.8. So that's particularly worrisome. But my question is on because of the rebound, even though it's an anabolic, can you gradually go off of Timlos over, say, a month or 2 months to help with the rebound? What are your thoughts on that?
Well, hold on. I never remember this. I never remember this because I'm pretty sure that Forteo to Evenity is really good. Or I'm pretty sure Forteo to see Forteo to one of them. Dr. McCormick knows is cold, but I have to look for Dr. McCormick's notes. And do you remember? I have it in the. Do you remember, Anne? I never remember.
No, I don't remember either.
I don't remember, but you're talking about Timlos though, right?
Yeah, but
It's the same
Timlos and Forteo. So
similar.
so there's only one stack that makes sense from anabolic to anabolic, and I think it's Forteo to Timlos is good, but but that that Avenity to Timlos is bad, and it's only going to take me a moment to find my notes from Dr. McCormick, and then I'm going to know right away.
And Dr. McCormick came to our program, so we have a whole entire talk for practitioners from Dr. McCormick, who's so incredible. He's like our favorite person in terms of really figuring out how to use an integrative approach in terms of, medication as part of an integrative approach. And
Is he the one that spoke a while back? Because I've listened to a number of your broadcasts. Is he the one that said you should go off with a bisphosphonate for 6 months and then you'd be okay after taking an anabolic? Maybe I'm mistaken. I'm not sure.
well, he's a very, like everyone else, you can't just stop the antibiotic. So most people use IV reclass. That's the one, so that you don't get the rebound effect. So
But so Prolia is the one that you absolutely have to do IV reclassed. If for Evenity and for Timlos and Forteo, the rebounds are not as bad, but you have to do a bisphosphonate. I mean, you could do if you were on Forteo and Timlos, or you were on Evenity and your hips were still really bad, you could do Prolia next. But if you could do Fosamax or Actonel, um, some people are actually now doing bioidentical hormone replacement therapy as their rebound medication for Forteo or Timlos or Evenity. But yeah, so those numbers are so high that I would stack the anabolics. I, Paula?
You would continue the anabolic?
Hey, Paula, not
Yes.
not Forteo and Timlos, especially if there's a deck. Can you go into the our module and medication and see which is it Forteo and Timlos to Evenity, or is it Evenity to Forteo?
No, I have it. I've got it pulled up. It's Forteo and Timlos to Evenity.
That's what I thought. That's what I thought. So if I had a patient with numbers like the ones you just described, I would be recommending that that patient go on Evenity because that spinal T-score is really severe and it's kind of a little bit of an urgency. And so I would be having my patient talk to their endocrinologist about Forteo to Evenity.
So the one problem with Avinity is because I have some heart issues with AFib, and that was
Mm,
not advised.
mm, yeah. Well,
So
then
what about going with, I mean, with a bisphosphonate? I mean, I don't know. It's really concerning, to be really honest.
yeah.
You fractured.
I mean, so if I had a patient, the first thing I would do is LP little a and a coronary artery calcium score, and then I might think about ablation of the AFib, and then I
My,
might.
cal my calcium score, in fact, is 0. Um,
Great.
yeah. So, wow.
LP little a.
So I also have arthritis, and I did the REMS test, and it showed not the results that weren't nearly as bad as this. But one thing that was worrisome with the REM score is that it also showed it going down in the same direction as the DEXA scan. But why would it go down? I mean, I was very faithful on Tumlos for 2 years, had no side effects. It worked fine.
Yeah, I don't know those kinds of things. Probably the thing to do is get a consultation with Dr. McCormick.
Okay. All right. Okay, that's a good idea. All right. Thank you. Appreciate it.
Yeah. Yeah, probably I'd do IV reclass for a year.
You would do reclass for a year? Okay.
Probably.
All right.
It
Thank
just
you.
depends on what the CTXs and the P1NPs are too.
So my CTX has
Certified
gone
integrative bone health practitioner.
in, my CTX has gone from
Certified integrative bone health.
has gone from 695 3 years ago, or almost 4 years ago, down to 352, and then last year it was 268, and in the middle of last year it was 175, and now just a couple days ago it was 320. The PM1P went last year from 32
Okay, I got it.
to 35,
Okay,
and
I
then
got it. I got it. I got it.
oh.
Yeah. Too much information will kind of put me in trouble, actually. Yeah, I think a consultation with Dr. McCormick might make Dr. McCormick talks about measuring IGF-1 and that if IGF-1 is out of range and it happens to relate to blood sugar and insulin resistance. If IGF-1 is out of range, people don't do well on Forteo Timlos. So maybe get a leptin, IGF-1. Yeah.
All
Okay.
right, let's put Dr. McCormick's information in
Oh,
Yeah,
qualification.
we could put
Paula
that
has
in
it.
chat.
Okay, great.
So do you recommend doing like 2.5 years of Timlos?
2.5 years of Timlos.
2 years?
I mean, why? If Timlos doesn't seem to be working and making things worse, would I consider continuing it in my patient? That doesn't make sense at
Yeah.
all to me.
Okay. No, that's kind of my thought too. So
Yeah, it does. It's just there's a reason why it's not working, and if you don't know, if I as a doctor don't know why, I mean, first of all, I'd have my patient go to Dr. McCormick. I do it all the time, you know.
mhm.
And, I talked to Dr. McCormick, well, what do you think's going on? First of all, I'd check an IGF-1. So metabolically, there might not be enough activity for Timlos and Forteo to be working. So yeah, but if I didn't know why, I would stop it. I would have my patients stop it.
Yeah, well, I'm stopping it now, so I'm
And
expecting.
then I would like really with a CAC score of 0, I would do a bunch of the Cleveland Heart Lab stuff. I do LP little a, I do LPPLA2, MPO. I try to get my patient an ablation. I try to do anything I could to like get that patient on Evenity, but there's look, I'm not as good as Dr. McCormick on meds.
Okay.
I'm decent, but I'm not as good. So he's the guy.
All right, thank you. You'll put his contact in the
Yeah,
chat?
look, Paul already did.
Okay, thank you so much. Appreciate it.
Yeah, you're welcome. Barbara, we got back
Hi, I'm back. Sorry.
minutes.
Well, I feel bad for Cindy, but actually my spine's even worse than hers. But I've never had a fracture and I haven't lost any height and I'm 68 years old, which is kind of amazing. And my hip area is in the osteopenia thing. And I did start Timlos and now I'm worried, oh wow, I hope it's going to work for me, after hearing her story. But I think,
So Barbara, that's unusual. So
okay.
don't go down that rabbit hole. Mm-mm.
Because my P1NP and did shoot up, so I think that's a good sign,
And
right?
that's the other thing too, right? Is that the ratio of the CTX and the P1NP is really important when you're looking at meds.
Yeah, you know what? My doctor let me have the P1NP and she wouldn't let me have the CTX after 3 months. So I don't know how the ratio is. My baseline,
You
I
can
haven't.
order all that stuff yourself.
Yeah, I just figured that out. Yeah, I think I'm gonna do that. A quick question that though, when you're on an antibiotic like Timlos Forteo, it relates to your thyroid. Do you think that it does any damage to your thyroid or makes it sluggish later because you're pumping in this hormone and does it get,
Parathyroid.
I'm sorry, I meant your parathyroid.
Parathyroid.
Could it
It's
do
so
damage
what's
down the road?
happening, the reason why Forteo and Timlos work is because it's pulsatile. So a continuous high PTH will damage your bones, but a pulsatile PTH encourages it to. I used to know a little more about this, but I kind of forgot. But I know it's the pulsatile nature of the PTH is what drives the formation.
But it doesn't hurt the parathyroid gland after 2 years of this kind of stuff going on. I mean, you haven't heard anything about that.
I
That,
have
that's
I have
good.
not heard anything about that.
Okay.
No.
Yeah, that's good to know. Also, can you be on an anabolic and HRT at the same time, as far as you know? Because I'm
You
on.
can. You can.
Okay. To be honest with you, I think the fact I had an early menopause, early 40s, I'm now 68, and I went on an estrogen patch early on. I don't think it had anything to do with my bone density, but I do think because of that, I haven't fractured. I should have fractured my spine. I twist, I bend, I lift things, I do all this stuff. People are shocked.
Well, you at the very least need to do R&R because Margie will tell you all the stuff that you're not supposed to do.
Okay, I was going to ask you about that when you're next, because my daughter's a registered dietitian. I know a lot about that, but I'm not practitioner. But your R&R class, when is your next one of those?
Usually
No,
we
sign
have
up.
the next one in August or so. It's
Okay.
gonna be in a couple months
Okay, I'll sign up for that. And that's
after the summer. Yeah,
you
give
know,
us your email and then Paula will put you on the wait list.
okay, great. Thank you. And thank you for doing these.
You're welcome. All right, so it's 3:57. Margie, were you okay with us doing Ginny and Lisa and finishing off there?
Sure.
Okay. Ginny?
Oh, thanks again. I was wondering your opinion on starting BHRT later, like at age 68?
Oh,
Yeah, I have my patients do that all the time.
Okay, great. Thank you.
That's easy. Lisa?
Yeah, I had a question. I don't know if you can answer this. Any thoughts on cartilage loss? Because I know we're talking about bone here, but I have bone on bone in one of my ankles. I think I'm a little bit left in one of them. And I heard stem cell therapy is helpful, but any comments about cartilage loss in addition to bone loss?
Yeah, so there's a product by Calroy. It's called Cartigenic, Cartigenix. It's got boswellia and celery seed extract in it, and they say that it's got some regenerative capabilities. I think I also would, the classic is chondroitin sulfate and glucosamine. Those are the building blocks of cartilage. So you got to make sure that you have those building blocks.
Do you have any knowledge of stem cell? There's patches out there, there's injections, any knowledge?
Um, I mean, I've used BPC 157 all the time. Maybe if you got a BPC 157 patch and stuck it on your ankle, that might be a good idea.
Is that a peptide?
It's a peptide.
Oh, cool. All right. Thank you so much.
Okay.
All right, look at us like ending right on time.
Yeah, so thank you everybody so much for being here. And I hope really that what you heard gives you a new way of thinking about bone health and what's possible for those who are practitioners, what's possible for your clients and patients. And for those of you who are listening and this resonated with you and you're feeling the pull to go deeper, we would love to support you inside the program. And if not, I just hope that you still take what you learned today and start using it because your clients and patients really, really need this. So thank you again for your time, for the work you're doing, and for being part of our conversation. And I'm just going to change the view for a second. And did you want to say anything, Dr. Millman, before we end? Thank you for really putting together such an incredible.
Oh, I think that, one of the things we do is what should we come up with a
Oh,
word?
you want to do that? Okay.
Yeah,
I
yeah,
always do that in my classes where
yeah.
we come up with a word that we just all say goodbye and come up with a word. So what word? Anybody, do you have a word?
Oh, um,
Anybody have a word? Any of our practitioners have a word?
I don't know. I'm just kind of thinking of like building this army of practitioners that's going to change the world, but I can't distill that down into one word.
Well,
Anybody else have any ideas of how we can do that?
that's our goal. That's why we started this. We were both, that's why we started this because people like Anne and Kimberly and Joni are going to get out there and just be helping so many people. It's just so incredibly wonderful to us. So what's a good word? Anne,
All
you have?
right. Well, Lisa was saying blessings. What about blessings?
Okay.
Could be
Excellent.
a blessing for everyone,
We'll say blessings. So just
including
count of
us.
three, we'll say bye. Blessings. Ready? One, two,
Okay.
three. Bye.
Bye.
Blessings.
Blessings.
Blessings,
Blessings.
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 Bye,
Thank you.
Mary.
Bye,
Take care.
everybody.
Blessings.
Bye.
Aloha.
Bye. Thank you, and Kimberly and Joni for coming. Really appreciate it. Bye. Just getting the chat here, wherever that is. Paul, are you still there? Well, oh, and here's the chat. Okay, so I'm trying to keep it.